This is part 3 of special needs pregnancies. Advanced maternal age. We also call it AMA and is not to be confused with against medical advice. So what are the risks of our older mother? Well, their ovaries are aging, they have less of them, and they end up having infertility. They also have an increased risk of genetic problems. Older women come to pregnancies with chronic diseases in place, and the most common are diabetes and hypertension. In addition, as a woman ages, there are increased risks of them developing uterine fibroids, especially in African American women. And with age comes grand multiparity. And so when we talk about advanced maternal age, we're not talking about that primip who comes in at age 40. It can be somebody who is age 48 and this is her 8th pregnancy. So a grand multipara, or we call them the grand multip, is a woman who has had over 5 or greater live births and or stillbirths over a 20 weeks gestation. And then we have great grand multips, which are over 10 live births and stillbirths that are over 20 weeks gestation. So my mother was a grand multip because she had 8 live births in an 11-year period. So how common is this? Well, the most recent statistics are from 2013, and close to 3% of live births were women having their 5th child. 1.5% were having 6th or 7th child, but only 0.3% were on their 8th child or more. And so the risks that come with grand multiparity is higher incidence of postpartum hemorrhage. We just have an old, tired uterus. Placenta previa, especially if these have been cesarean sections. There's a risk of uterine rupture because this uterus has been stretched many times through pregnancy. And then, of course, with age comes an increased risk of venous thromboembolic issues. So this table shows what the genetic risk is for chromosomal abnormalities. And so when you're 25, any type of genetic chromosomal anomaly is 1 in 476. But boy, when you're 45, it's 1 in 24. So there's 24 women age 45 who are out there pregnant. One of them is going to have an abnormal child. When we look at the Down syndrome risk, when you're 20, your risk is 1 in 1,477. I'm sure every one of you would take that risk. But then when you're 45, it's only 1 in 35. That's pretty common. So complications that are associated with advanced maternal age will be your pregnancy-induced hypertension, gestational diabetes, multiple gestation because they have a decrease in their ability to conceive on their own, so they're using assisted reproduction techniques, and so they end up with twins and triplets. They are at high risk for going into premature labor. They may be at risk for dysfunctional labor because, once again, this uterus is getting tired. Surgical births may be more likely in some. And if they have hypertension or they just have poor perfusion overall, let's say they've been a lifelong smoker, then their infants are going to be small for gestational age. So you've learned about all of these complications, and this is just a little piece of the advanced maternal age mother is going to have one or all of these conditions. So be on alert for it when they're admitted. So I put the abnormal fetus in with advanced maternal age because the risks for them are much greater. It's a sad situation. Some of our patients may already know when they come to labor and delivery, and some may not know. And it isn't until the child is delivered that we look at the baby and it's like, uh-oh, there is something wrong. And depending on what the defect is it compatible with life? What kind of quality of life is this abnormal baby going to have? What should we do? The parents go through grief and mourning. Some of them are feeling very guilty because they wonder, what did they do? What did we do that we got this kind of a child? Some, with their religion, think that God is punishing them, and that's why they were given this child. Some cultures actually ostracize the family if they end up delivering a baby that has special needs. What we want to do is promote bonding between the parents, the neonate, and the family members. We want to give them time. If the baby's been born with a defect that's not compatible with life, we need to promote the environment where they can be together with the baby. And anytime they want to have that baby come in and out of the room, allow them to do so. It's important that we communicate what's going on. If the baby's been taken over to the neonatal intensive care unit, we want to communicate with our colleagues and find out what's going on. And then we want to promote the follow-up care. If this baby has special needs, we're going to collaborate with a variety of specialists so that everybody can provide the best care possible to optimize this child's life. So how you handle this type of a situation has a direct effect on the couple. If you're afraid, if you're looking at them with evil eyes, or, sometimes nurses have attitudes, it's going to affect their ability to cope with this situation. So like I said, provide an empathetic, caring environment. It's very difficult for these parents. They did not have this vision in their mind the entire time that they were pregnant, and they feel this as a loss. If the baby ends up dying, we need to acknowledge that the baby existed. It is real, it was real. Refer to the baby by its correct gender. And if they have named the baby, we're going to call the baby by its name. If the baby has gone off to the NICU, we want to encourage them to take a picture of the baby, even if the baby has a lot of anomalies, because they can at least see those pictures when they're not with the baby, and it helps them to bond. If the baby dies, many of the hospitals provide a memory box, and so we'll snip a locket of the hair, we'll take handprints, and we'll take feet prints. We may put in the hat that the baby wore or a blanket. You want to allow them the privacy that they need, but you need to let them know that you are available and that you are not avoiding them. If the baby is taken to the NICU and the nursery and then the baby dies when they're not there, we want to reassure the parents that the baby did not suffer in any way, shape, or form. And so I put a link on Blackboard called Grieve Out Loud, and this is a support group for perinatal and neonatal loss. This ends part 3.